Good morning, everybody. Thank you all so much for coming. Thank you to the Health Foundation of South Florida and Florida Memorial University for convening us this morning. As we have in the past 2 years, we've had really engaging and dynamic summits, and we expect we'll continue along the journey that was set forth by Dr. Adams, Ms. Chant, Health Foundation of South Florida officers, and our dynamic speakers this morning. I'm happy to kick off this policy discussion this morning with our esteemed panelists. You have profiles set forth in our program here, and I don't want to spend too much time. I'll invite each of our panelists to give a brief overview of their experience and perspective as we fold their comments into our discussion. We have Erica Monet, Lee, Linda Elam, Yolanda Cash-Jackson, and Avrina Schools-Cropper. So we're going to get into the discussion again. I'm going to invite my esteemed panelists to, again, fold in their experience and perspective as we answer the questions and delve into the topics. We believe that'll be a more fruitful use of our time because we have so much to cover and only a limited amount of time. So please enjoy the discussion. Thanks. Okay, so can you hear me now? Okay, great. So we're going to move on from the morning presentation and really speak about the policy implications of the political determinants of health. And I just want to give some prefatory comments before we move on to our discussion. And so we have like the political determinants of health that defines policy really as it means that the means by which government commits its decisions to forms of law, regulation, procedure, administrative action, plans, incentives, voluntary practices of government, and those are all designed to achieve specific health-related goals. And I like for all of us whose eyes glaze over when we hear policy to use a shorthand when I talk about policy, and that shorthand can be understood as the rules and resources that shape behavior and improve outcomes. And so rules can be, they can stop harmful conduct, they can compel or incentivize beneficial conduct, and the resources, of course, which means money, it can fund health-related practices and priorities, and it can also be used as an incentive or a carrot to really shape influential or beneficial behaviors, and also as a stick, as a penalty to disincentivize or stop harmful behavior. And then government can direct appropriations or spending. It can allocate tax credits, et cetera, to shape behavior in that way. And then one final thing, which I think is important for us to understand, is that government, there are two kind of pathways of policy manifestation. One is through government, and then this is kind of a binary consideration. The other is through market forces. And one of the kind of primary considerations we have to understand is that the government shapes the market. The market is not free. It operates under rules and regulations that are shaped by the government. So that's kind of my shorthand description, understanding of policy. Then, of course, policy for all of us, so we understand. It's implemented at various levels of government. Obviously, we have the federal government, the state government, local government, that can be municipal government, county or city government, and then also through regional coalitions of cooperation. And then when you silo the implications of policy at those levels, you can talk about the executive or the governor or the mayor. They can implement policy executed through administrative agencies of the executive branch. Obviously, the executive has to execute the laws that are determined by either the legislature, in the case of the state, or by the city council or the commission, which enacts ordinances on the local or city level. And then, of course, judges and courts implement policy through orders and decrees, and also through the interpretation of laws that were passed by the legislature. So just want to give a framework of kind of the policy landscape that we're discussing today, and then as we go through with our panelists, I want us to keep those kind of frameworks in mind. So kind of the first topic of conversation I invite our panelists to discuss. So in his book, his amazing book, The Political Determinants of Health, Daniel Dawes, he compellingly describes the effort to pass the Affordable Care Act and how stakeholders and advocates navigated the challenges and opportunities to achieve success. So I'd like each of you in your areas of expertise to please discuss and help us identify current challenges or current opportunities that exist to advance healthcare policy in your respective areas. And that's also, and we can discuss this as we go further, in the current context that shapes the policy environment, and we can get into that more. So I'm going to invite you first.
Thank you. So my name is Dr. Averina Schools-Cropper. I am representing Centers for Medicare and Medicaid Services, Office of Minority Health. My office is one of 8 offices that was established by the Affordable Care Act. And so Dr. Dawes kind of talked about kind of setting the stage and bringing health equity to the forefront in the agency. In our agency, we really want to advance the policies, understanding that it affects many lives. Our mothers, our fathers, our aunties, our uncles, brothers and sisters. And so we have been intentional in how we have put forth many of the policies that we're going to put forward and have finalized. CMS has been intentional as well as defining what health equity is, right? And so we have to be able to define in order for us to ensure that the policies that we are putting forward, we all are on the same page. And so our definition and what we have used to guide us is the attainment of the highest level of health for all people, making sure that it is fair and that individuals have a just opportunity to obtain their optimal health. CMS has really been intentional, has established a bold plan to meet our mission, which is really to ensure that the healthcare system is strong and that it is also resilient, particularly those individuals that are served by our programs. And so there are many policies that we've put forward, and there are many opportunities. Maternal health has been a big opportunity for CMS. The Department of Health and Human Services established a blueprint for improving maternal health. And that blueprint is a whole government approach. It's all agencies across Department of Health and Human Service to advance those individuals who are unduly influenced by inequities and disparities in our country. And so I'll give room for my other panelists, and we'll dig deep a little into the specific policies that we're putting forward. But there are many opportunities that CMS, an investment that we've put forward to ensure that we are advancing health equity in our policies.
That's great. Thank you, Dr. Schools-Cropper. And before I get to Ms. Lee, so Dr. Schools-Cropper is her role is an example of how policy gets implemented. Obviously, we speak about the passage of the ACA, which created a mandate for the Centers for CMS to pursue and execute health equity, and here is the embodiment of the execution of that policy decision by the government. So I just wanted to
Thank you for giving that context.
right. So we're going to move on to Ms. Lee next.
Hi, good morning. My name is Erica Lee. I work for the Florida Policy Institute. We are a nonprofit, nonpartisan think tank here in Florida that focuses on advancing policies that will benefit the wellness of all Floridians, no matter where they come from. And we do that through our roadmap to shared prosperity. So we're always advocating, researching, and letting you know what's going on at the state level in terms of policy. I am our health policy analyst, so heavily focused on Medicaid and children's health insurance. Now, I enjoy this conversation. I think where I lie is at how the state implements what's going on at the federal level, right? It's really interesting in terms of our health insurance programs here and across the United States. So as we talked about the broad context of Medicaid earlier with Mr. Daniel Dawes, we saw that each state implements their each state implements their laws based off of what their state believes they should do. So how does that play out in the Florida context? We always look at that. And so right now, in the context of Florida and Medicaid, we are in a particularly interesting circumstance. This is one of our largest ways that people can access health care in the United States. However, we know that Florida is one of 10 states that has not expanded that program. And so we leave a lot of people without care. And over the last year, there were federal provisions that ended that were keeping people enrolled in Medicaid throughout the pandemic. And as that disenrollment happened, you know, it was really significant to see what happened in the state of Florida because of that. We can get into the specifics now or later as part of the conversation, but.
Yeah, we can cover it going on. I think that's a good starting point.
Right.
And so just I wanted to, again, give a context for Ms. Lee. Often with healthcare policy, there's a relationship between the federal government, the state government, and county governments. And there can be policy mandates from the federal government, or again, incentives or disincentives that get mediated through decisions by the state legislature or the municipal body. And Ms. Lee is operating in that policy space where she's trying to translate federal decisions or opportunities into local decisions here in the state of Florida. So that's the policy space in which you operate.
Yes, that's the policy space in which I operate. So interested to get more into the details a little bit later. So I'll go on and hand it off.
Good morning, everyone. It's a pleasure to be with you here today. I'm Linda Elam. I am a managing director with Manat Health, which is a professional services firm. I'm in the DC office. By way of background, I'm a health services researcher by training, OG public health person. I was social determinants before social determinants was cool. So I have a very particular point of view about that. I have worked at the federal level at HHS as an Obama appointee in the Office of the Secretary, where I did work on policy related to disability, aging, long-term care, and behavioral health. I have also served as Medicaid director for the District of Columbia, and the District of Columbia, for the purposes of Medicaid, operates at the state level. So I was state Medicaid director, which is very important in DC because, you know, we're big on our taxation without representation, as you may be aware. And so I have experience working at that 30,000-foot federal level, understanding trying to have the greatest impact across the widest possible area, but then also understanding the challenges of implementing that policy at the local level, tailoring it and understanding the nuance and obviously the political situation or the political atmosphere in the District of Columbia is probably quite distinct from what we have here in Florida. So the challenges are different, but the challenges persist. And so I have a lot of lessons learned about how to do that. I've also worked in the private sector operating a Medicaid health plan, and a lot of my work has been obviously in the Medicaid space. So understanding what the possibilities there are in terms of advancing health equity through Medicaid, but again, what the limitations can be as well. And so I think we'll dig into more of that as we go along as well.
That's great. Thank you, Dr. Elam. And then we have Yolanda Katz-Jackson.
Hi, Yolanda Cash-Jackson. No, I don't work for the government. I really don't like the government. No, just kidding. But I lobby the legislature, so my job is to be a waymaker. Waymaker, promise keeper, all that good stuff. And that is to take the policies that the state of Florida has implemented, then look at what the federal government has done, and then make a way to get dollars and policies back to communities. I have worked in the healthcare space for quite a while now. I saw Dr. Adams and the Fire Trust people gave me my first start as they were minority physicians trying to do business with ACA, and that was quite a feat. But we learned a lot. We learned about advocacy, and I work in advocacy in this space Most recently, I've worked with safety net hospitals, trying to figure out, make a way, another way out of no way. And then most recently, we did have some successes with sickle cell, which I'll talk a little bit more about. But I do want to acknowledge the fact that we do have some legislators in the audience. I was surprised, Senator Rosalind Osgood, if she would just stand. I don't know if we have any other legislators in, but these are the people that help us make a way, help us figure out how to sell what the legislature is buying. And so I think on this panel, I'll give you a more practical approach on what to do when you need to make a way out of no way.
That's great. All right, so I'm glad we got that opportunity to kind of level set, find out where our kind of perspective is in the policy space. And I think one of the main challenges, Dr. Dawes and the political determinants of health and also the social determinants of health framework, we speak about kind of voting. Government is what executes policy, and policy obviously kind of executes the government decision. Overriding that, or at least influencing all that, is context in which we operate. You made reference, Dr. Elam, about the context we operate here in the state of Florida. And I think, without putting too many labels on it, you have a challenge, particularly in the health equity space, that we're trying to navigate, is there's a tension between data, right, and ideology. And I think we can get into why ideology and what is driving ideology. But I'd like each of you to discuss, particularly with you, in terms of how do we navigate that tension between data and ideology, and how do we, given that tension, where there are opportunities and challenges to advance healthcare policy? So,
Well, thank you for that question, Alex. I think recognizing that there is duality is that people come in with a theoretical view of how to approach these hard, complex issues, and understanding, as Linda mentioned, is that there is that practicality, right? So what we think upstream theoretically does not always work in the practical realm. Now, with that said, I think CMS has really thought about how we utilize data. We've created or wrote a white paper that essentially assessed our data capacity. So do we understand what is happening, just baseline, right? And then taking that information and having that to inform how we are implementing and executing policies through Medicaid, Medicare, and the health exchanges marketplace. And so when we sought out in getting feedback from our stakeholders, as well as gleaning information internally, we really found that it really requires, and really we found that there was a lack of consistent data collection, right? And so we have to be able to collect the right data to answer the right questions, right? Questions are very important. Our problem statements are very important in how we can address the issues and needs. And so in this report, we mentioned that the lack of consistent data collection at the disaggregated level, right? So these different levels really presents a barrier to understanding the needs of specific subpopulations. And so we've really took this to heart, and we've done so by releasing resources that can just help not just CMS and our internal partners, but stakeholders as well, understanding health equity related data definitions, its standards, and our ability to stratify across our programs. This will allow us to align, to make sure that these elements align across the programs so that we are efficient and that we really understand and focus on how are our populations affected, either, if you identify, sexual orientation, disability status, primary language, English proficiency. And so we really are taking a bold approach to ensure that we understand the data capacity. We collect a lot of data, but we want to make sure that that data is used amongst you all, researchers that are in this room, to be able to answer these complex questions, complex issues.
All right, thank you, Dr. Schoolscropper. Now, Ms. Lee, you operate in particular where this tension between data ideology and the space at the Florida Policy Institute as relates to Medicaid expansion, et cetera, and other projects. Can you kind of address this tension and how you navigate it?
Yeah, definitely. We collect data at the statewide level to see what's going on and how we can advocate for things that are implemented at the federal level. The data we collect really exists to try to keep our state agencies accountable for the services that they can provide. And then we also use our data to advocate for more funding across the realm. So when we look at our numbers and we look at our statistics of Medicaid, and when we look at, how many people have lost coverage, we have those specific numbers. And so given the context of, Medicaid specifically, I can say that, as I was speaking about earlier, over the last 2 years or so, we just started redetermining people for their Medicaid eligibility after not having done it during the pandemic, because during the pandemic we were trying to keep people enrolled in health insurance. So during that time, our Medicaid program in the state of Florida grew from 4.6 million people to about 5.5 million people. We were the second largest Medicaid program in the nation. And so it would be particularly important that these policies were implemented to, make sure people weren't losing care for administrative reasons. So the federal government put out lots of flexibilities that allowed for states to say, okay, this is how we can implement these so that people don't lose coverage because they're no longer eligible, but because or for procedural reasons, right? So those are the reasons that we talk about people maybe having moved during the pandemic, they can't be reached. 1.6 million people had never had to undergo this process in the state of Florida. So as we talked about that, we were tracking numbers and really just trying to see what was happening. We saw that in the state of Florida, during this redetermination process being reenacted over the last couple of years, that we have lost about 1.3 million people in our Medicaid program. And of those who were disenrolled, 64% was for procedural reasons, and that is heavily to do with the fact that Florida was the only state to not take up any of those federal flexibilities. And so when you talk about, sort of this, how does it get implemented at the state level? How do you use your data? We're using that data to say, look, Florida, you kind of messed up here. Now there's a lot of people who are languishing without care because you didn't take up these opportunities. And again, I'll add the added context that we are one of 10 states that has not expanded our Medicaid program. So people who are uninsured are also struggling. In order to qualify for Medicaid in the state of Florida, you have to be an adult, or you cannot be an adult without disabilities or children. If you have children, to qualify, you can only make about $72,000 a year. And people think about that and they say, a year? Yes, to qualify for this program. And so when we talk about the decisions that our agencies make, that our legislators make, that's how we use our data to say, hey, these numbers are very alarming, and what can we do in coalition to connect that? And we connect that with individual stories that are going on the ground through working with others. So.
Thanks, Ms. Lee. Now, Dr. Elam, you mentioned, again, your experience in the District of Columbia, and you made reference to the particular differences between that context in which you operate, the contexts in which we operate here in Florida. Can you comment more about your perspective and maybe help us, gain a little bit of understanding and strategies about how we navigate our context from your perspective?
Sure. So let me preface this by saying I am a nerd. Data are, I even use the plural, very, very important to me. And part of my education as a professional was that the data could be pristine and only get me so far if the ideology and if the machine pushing the ideology was strong enough to sort of render it immaterial. I commend the feds for the efforts to improve data collection and data integrity. It is hugely important. And it's also a marker that elections matter, because not every administration takes on this huge effort with such seriousness. At the state level, it's obviously equally important. There are states where data collection has been slowed down, if you will, based on the priorities of those administrations, the executives in those states. I feel fortunate to not have worked in such an environment, but I had other occasions to have my elegant numbers kind of be met with, all I know is, which meant I don't care, because we're going to do it this way, because this is the political imperative at this time. I think that, and I love saying Dean Dawes. Dean Dawes, I've known him a long time, so I'm excited to see his career trajectory, but the commercial elements as well, and that sort of component of what is promoted and what languishes, regardless of the data. I will say one other thing. If data reigned supreme, every state in this country would have expanded Medicaid quite some time ago. The numbers are clear. Medicaid is the largest source of federal funding in states across the country. So for anyone who's a fiscal conservative, we have good evidence to refute, not taking that up. The health outcomes data for states that expand Medicaid are also irrefutable. So that is just an example of how, sure, you need your data and you need to be able to measure your outcomes, but you've got to have a very strong game on the ideology, the politics, and the other elements such as the commercial determinants, if you will, that have a huge impact on your success.
That's such a great segue into the expertise that Ms. Cash-Jackson will share with us. She's got deep experience about navigating these challenges and finding opportunities where other lesser determined and creative advocates would find opportunities. So if you could, Elise, you talked about a recent success with sickle cell research, and also help us as advocates, stakeholders, and how we can strategize to find those opportunities, either at state or local level, to advance healthcare policy given our conditions, if you could speak to that.
So I will keep it very simple. I'm a very simple person, and lobbying and advocacy requires simplicity, because it has to be, keep it simple, stupid is what they say, and that goes in, for lobbying as well, and advocacy as well. You have to be selling what they're buying. If I'm only selling green shoes today, do not bring me black shoes. I don't want black shoes today. And so we've really learned how to master the art of putting language together, putting policy together that is aligned with the day. Legislators want to hear on the other side, they want to know how much money you're saving. How much money you save. Is that an awful thing to say for people who have suffered because of health disparities? Yes, it is, but that's what they're buying. So that's what we're selling. And we've done that. And sickle cell is a great example of that. One of the things that we learned through data was that sickle cell patients were not getting registered. They get registered at birth. There's an infant registry, but after that, when the kids, by the time they get 18, if you know anyone with sickle cell disease, or you spend a lot of time at the hospital, and they keep up with the adolescents. When they turn 18, we don't know where they are. That costs the state a lot of money. Am I right? Costs the state a lot of money. So we said, well, how about we make the registry beyond 18? We didn't say anything about black. We didn't say anything about anything. We just said, you know what, if you do that, you're going to save some money. And for a state that doesn't have Medicaid expansion that's going to have to cover that cost, it resonated. And guess who was our #1 advocate for this appropriation that we were using or seeking? Was the Speaker of the House. How about that? Well, if you know anything about the legislative process, if you have the Speaker, then you can sit back. That's like your mama bringing out the checkbook, right? So, and so he helped us craft the language because he had the resources, and we were selling what he was buying. He wanted a solution for this problem of not having these folks registered. Now, was there opposition? Absolutely. And I don't want to offend any academics in the room, but they get, you know, academic. And the reality is that we needed to get those funds. For the first time in the state of Florida, we have a $10 million appropriation for sickle cell, recurring. $10 million recurring. Now, you know I got a call that said the cancer people want the money. That's life. But we'll deal with that, going back to that Waymaker situation. So I think, you know, understanding what the legislators and lawmakers are looking for, what they're thinking, and then speaking in the language that they understand, and that is money right now, because the state's going to have to pick up all that stuff that they don't do with Medicaid expansion. They're going to have to pick up the cost. And we are starting to reshape that conversation. The COVID money is gone, so we have to reshape the conversation. Selling what you're buying.
That's great. That's really a great preface. I'd like to open up the for audience engagement and questions. I also want to help us kind of think through the progression of how do we advance healthcare policy. And I think the panelists, even before today, we talked about a progression about, you know, where do you start and how do you think about advancing policy based on what, you know, what your policymakers are buying. And one is like if you don't have the data case, is like secure a mandate of resources to secure the data, right? And then second, if alongside with that, if you have an existing program that seems to work and is supported by data, either you expand the eligibility requirements, you want to, like, you know, get an anchor and expand out, either expand the duration, expand the coverage requirements, et cetera, expand the resources, money. Okay, that's another progression. The third progression was, again, if either data or ideology supports the program, establish a whole new program, right? And those are like the big far-reaching pictures that we're trying to do. Beyond that, there are other kind of lesser considerations which I think are important. One is defense. Policymakers have to spend a lot of time, and Dean Dawes spends a lot of time talking about how, after the passage of the ACA, you spend all your resources defending the advance. And that's, frankly, we can talk about the ideological context in which we're today, but that's a lot of the work that we're doing, is we're fighting against retrogression. So halting retrograde action is another health policy intervention. And then the final, which again is underappreciated, which has to do with retrogression, is enforcement. Nobody talks about enforcement. I think that's a really important detail to understand about the context, not only in healthcare, but all kinds of areas of equity closing measures is just the plummeting of enforcement mechanisms. That means we have a lot of great laws in the books, but there's no enforcement. And that means that we have a huge gap between what we aspire to accomplish, what we actually accomplish. So I'm going to leave that context setting for questions for the audience members, so we can have further engagement on these issues.
For those who have questions, if you'd raise your hand, I'll get a mic to you. Any questions? Hands up, hands up.
In that case, let me.
Hands up.
Yeah, go ahead. Let's
Oh, I think the mic, is it on?
A good
Hello?
panel, thank
Hello?
you. My question is, what did I do? Okay. My question is Medicare and Medicaid. I'm a Medicare person. I do not qualify for certain things under Medicaid. It's like we are being cut out of the system. Certain things under Medicare, I have to pay for. Certain things, such as we're talking about health care now, they're not providing us that opportunity through the insurance companies. We don't qualify for the healthy food. And most of black people do have hypertension or diabetes. So they need that healthy food. I want to know what is going to happen to this system.
So I don't represent Medicare at all, but I can speak to some of the underlying issues that you're describing. And one thing I would recommend, every state has agencies on aging who can help navigate some of that, but Medicaid benefits, which I understand you're saying you don't qualify for, they differ from state to state. Medicare, however, is a national program. The rules, are the same across the country. And so what you may also be talking about is the difference between Medicare Advantage and Medicare fee-for-service. That is, again, something that your areas on aging folks can talk to you about. What I'd also like to highlight, though, and I'm happy to talk to you some more about it, but I'd like to lift up one of the challenges that I also think speaks to Dean Dawes's sort of exposition of where we are today, and it's the fragmentation of our healthcare system. No one would design a system like this, but it's because of the political imperatives that we fill in little blanks here and there, and then this thing pops up and we do this thing to solve that, and you end up with something that's just not logical. I'll take it a step further and say most Americans do not understand that Medicare does not provide long-term care. It's only a short period of time after an acute hospitalization that you can get rehab. Our long-term scheme in this country is being run off the backs, largely, of unpaid or underpaid caregivers, often family caregivers, who are often women and women of color. This is another example of where policy is not taking care of some of the most urgent needs, and I would offer because of who those people are that are being affected. So that's a huge, long conversation, but I just wanted to take that opportunity to shine a light on that.
Thanks, Dr. Elam.
Hello, can you hear? There we are. And so while we're also talking about what we can do about these issues that we see, and we talked about what the fiscals are on Medicaid expansion, right? A recent analysis from the Center of Budget and Policy Priorities showed that if Florida would have expanded Medicaid in 2023, it would have saved our state an additional $5 billion per year, generated an additional $5 billion per year from a federal 90% match for funding, right? And then FPI, we estimate that once we expand, we can actually save our state about $200 million a year, based off of other things that come in from the economic impact, et cetera, et cetera. And that would benefit over probably 700,000 uninsured Floridians at this point. And right now there's opportunity to receive even more funding for that with an ARPA incentive that's available federally that would bring our state an extra $2.8 billion in funding. And so when we talk about what we can do to expand this program, I'm not carrying a backpack around for fun today. I have actually ballot initiatives for Medicaid expansion because the conversation is getting lost right now, and the context of that is getting lost in our current administrative, I'll say muckety muck. And so what you can actually do right now is sign a ballot, sign a petition. I have about 100 copies, so don't leave here without meeting me at table 4 to sign one if you care about expanding Medicaid in our state. That is one opportunity that you could actually take today as an advocate. That would be great. If not, you can go to floridadecideshealthcare.com to help expand this program too. That is the ballot initiative's website.
That's great.
Hi, so I'm going to ask a question from a different perspective. As a policymaker, someone who's very into the interwovens of Tallahassee where you don't even talk about Medicaid expansion. You just get told right at the beginning of session, we're not doing this. My background is public administration. And what I continue to see is our silos. We don't bring together. I'm sitting here saying the people that could change these laws, they're not here. I'm here because I'm wired a certain way and I have to learn and know. I just can't make policies that could be possibly killing people because of ignorance. So how do we get the data? Because there is an ideology. Anything from Biden, we don't want. Anything from this group, we don't want Trump. And it really has nothing to do with saving lives and what we continue to see happen in our communities. Jonathan Metzl writes this thing called Dying for Whiteness. And I promise you, I wish I could afford to buy a copy of it for like every white person in a decision-making position so that we move away from its impact in black people or Hispanic people. It is literally hurting and killing all of us. So what are some of your thoughts about bringing the disciplines together? The sheriff is dealing with health issues, education system dealing with health issues. They don't necessarily ask the health experts. Now we see the government trying to run the schools and dictate the content. At some point, we have to have some discipline integrity that we let the individuals in those disciplines like lead us. Say COVID ain't real, but the doctors say it is, so I'm gonna follow the doctor. But that is a conversation that I believe is so critical in this moment that causes us not to do a better job when it comes to policy making. So I would like to hear your comments about that.
Yeah, that's great. Ms. Cash-Jackson, and then Dr.
I
Crawford.
think, Senator, I think that the thing that we have to do, we have to advocate, we have to get involved. And it's very simple. How many people here are registered to vote? Everybody's gonna raise their hand, right? Everybody's registered to vote. How many people know the name of their state representative? Not as many people. How many people know the name of their state senator? Not as many people. How many people know the name of their member of Congress? All right. Of the people that know the name of their representative, how many know whether or not they sit on the health committee? My point, you don't know. So we don't, well, it's online. Everything, the kids, I'm living with a 21-year-old is at my house. Everything's online. You know? I had to put coolant in my car. He looked it up online. So the point that I'm making is that we all have a responsibility to put the mask on ourselves first. And that is, we need to know who our state legislators are. If you are affluent, if you're making more than $200,000, you're making more than $150,000, more than likely you're not in an underserved area. That's not where you're living. And those are the people that are making decisions. When legislators come to Tallahassee, they're ordinary people. They only become an expert once they get sworn in. Right? So it really requires us to talk to them. You need to know who represents you. You see them in a grocery store, and this is the last thing I say. Ask yourself if they're, and I know I saw Dr. Barr, I saw Rosalind Frazier, they know that I say it all the time. Will they answer your phone call on a Sunday night? Do you have a legislative friend that will answer your call on a Sunday night? That's who you need to be telling this stuff to.
Yeah.
So it's very simple, and I don't mean to oversimplify it, but put the mask on yourself first. Get to know who your legislators are and educate them, because they only got smart when they got sworn in. That's it.
Thank you. Dr. School-Scrapper.
Hello? Okay. What I'll say, and that's a great question, one of the things that I've observed from the federal level is how leadership is approaching solving these complex problems. It has been demonstrated through executive orders, so the Biden-Harris administration has released several executive orders, but there have been orders that have allowed us at CMS to do our work. And so one of the things is ensuring that the leadership is there to support the effort, right? You can't do anything without attention and investment. And so what we found is that Congress has really been intentional and helpful in the healthcare space to ensure that we can move the needle. And so we're doing that by, data is important. It's making sure that it is standardized. We're all speaking the same language is important, because if I'm saying health equity is one thing and another agency is saying that it is something else, we don't have alignment. The other thing I'll say as far as dismantling silos is understanding the missions of your partners. We all have different missions. We're all servicing different people. It may be a provider, it may be an advocate, it may be an individual. We have to understand that in order for us to come together and determine and figure out where can we start. Also understanding that we have data, but what do we not have? What questions we can't answer with what we have? Administrative data was not intended to answer some of these public health questions and issues. And so we have to recognize what are the limitations, right? And it may require policy in order for us to advance and enhance our data collection efforts.
That's great. Thank you.
And lastly, I want to say that our advocacy efforts also do not exist in silos, which is great. Florida, you know, there are so many of y'all who care, who are doing this work, who have connected with organizations like Florida Policy Institute, and you've asked us for data, and in Coalition, we've collected stories to match the numbers and say, this is a family that's actually been impacted. And so we do this across our categories. We've got analysts in social justice, education, immigration reform, and things like that. And so we always are looking for partners, and so that we can get an idea of what's going on the ground, so that we can match your stories with the data, and then we take that to our legislators as well. So we're always developing those partnerships, and we do speak to legislators often about how the folks in our communities are being impacted with what we're seeing at the statewide level, and we continue to advocate. And Florida does a really great job of that.
Thanks. We have a question, I believe.
Hi, I'm really appreciate your commitment to data, because as a medical school in Georgia, we face some of the same things that you all in seeing how the data, for example, supports Medicaid expansion would save lives, improve healthcare outcomes, et cetera. But my question this afternoon is about what are you all looking at as a strategy to engage the private sector and business in getting behind some of these things? Because, like some of you have already emphasized, you know, the morality of what we want to do, or the equity, that's just going in one ear and out the other. And one of the reasons I asked this about the private sector is we're seeing all across the nation how it's not just healthcare that's not being expanded in terms of coverage, but we're allowing hospitals and services to just close. I mean, and it's like, you know, we'll fuss for a moment, and it's like it's gone. You know, we just had Atlanta Medical Center close in Atlanta a year or so ago, and it's like, wait a minute, this 500-bed hospital been here forever? Our state legislators, oh, we're just going to give $100 million to Grady, and that's going to take care of everything. It's like, what? So how might we engage the private sector in putting pressure? Because, again, they're behind a lot of the lobby efforts to get a lot of things done. Thank you.
That's a great question. Thank you for your question. And I will remark, I think, and Dean Dawes discusses this in his Political Determinants of Health book, and I think Ms. Cash Jackson can attest to the efficacy of making the economic case for health policy interventions. I'm not saying that that's the most moral or straightforward case, but I think the release of the report by Dean Dawes and his group, I think, you know, estimating the $1 trillion lack of productivity and cost associated with the failure to address health equity. Those are the types of data recruitment strategies I think you can use to enlist the business community. That's one strategy I can understand. I'd be interested to hear you, Ms. Cash Jackson, if you have other strategies besides that. And then the other strategy, I know Senator Osgood, I think she's a member of South Florida on the Senate Health Policy Committee. So working with committee members, appropriations committee members, particularly in the House and the Senate, to strategize, triangulate between them, and what makes the best advocacy case from their perspective that could bring their committee members along, I think is a strategy.
I mean, listen, the bottom line is the bottom line. You have to answer to the people that, you know, your shareholders and all that. That doesn't change. What attracts a business community is good business and speaking in terms of what makes sense for them. And that's unfortunate because sometimes it doesn't match. But that's what we're facing. It's the basic communication again, the basic advocacy again. I can tell you as a lobbyist, and I would tell you, don't tell anybody this, so keep this a secret in this room. But if you get calls from, if you call legislators' offices as citizens, they don't even pay attention to the lobbyists. I'm telling you, it's the truth. Am I right, Senator? So, you know, we have to go back to the basics, and I hate to be making it so simple, but it really is. You know, you make calls, you send emails as a citizen to your legislators. They track how many calls they get and when they get them and who they're getting them from. So we may have to go back to basics in trying to influence some of those decisions. The other thing I want to just mention that I want to give hats off to everybody that thought that a Black Health Summit was still cool. Because, you know, with DEI and DEI, I mean, it's important that we call this a Black Health Summit. And we continue to speak truth to power as to how health affects Black people, period, dot.
That's great. I'm not sure how much more time we have. One more question. If we could have Dr. Elam, she has a brief comment, and then we'll have a follow-up question, and I'll wrap up.
Very quickly. So this also brings up the issue of venture capital in healthcare and the importance of regulation. In order to open a hospital, you have to have a certificate in need in most places to demonstrate that that hospital is needed. But to close a hospital, not in Florida, okay, sorry, in other places, but you can close down not only hospitals, but nursing facilities with impunity, regardless of what's happening in those communities. And so that's also a place where community advocacy, communicating with your legislators, and expressing that community need is so important because the balance of power is off there. And I would say that a lot of these political determinants and social determinants conversations at their core are about sliding that power back and forth between larger interests and the interests of the folks who are underserved.
We have one more question,
One
I
more
believe. and then-
question. I don't want to be that person between all of us and lunch. So very quickly, thank you all for being here. My question is specifically for Dr. Schools Cropper. I'm the VP and Quality and Health Equity Officer for Jackson Health System. That's Miami-Dade County Safety Nets Health System. CMS is requiring hospitals and health systems to attest to a health equity structural measure that focuses on their commitment to address health disparities. And also has asked hospitals mandatorily now in January to start collecting data on the social determinants of health. Can you briefly share with us what is CMS's futuristic strategy at a federal level and what guidance will be provided to the states on seeking funding to help hospitals and health systems address these disparities?
Thank you for your question. Though I can't speak specifically about the structural measure that you are speaking in, what I do recommend is that as we are communicating our policies to our health plans, health facilities, to really think creatively, innovatively of how those policies are impacting the people that you are serving. We talk about data, and that's very important so that we can provide the evidence to support whatever change that needs to happen. All of our federal regulations and policies are open for public comment. That is a way for us to really think and really utilize the information that is coming from our stakeholders to ensure that these policies are not adversely impacting communities of color and those economically disadvantaged. And so I encourage that as we continue to communicate to our stakeholders that we need to hear that feedback. Feedback is the only way that we can be able to, we have something in mind and we think it will work, but we need to hear from you to ensure that, hey, this is something, this is an unintended consequence, or this is helpful. Why? Because this can provide a structure to build in other jurisdictions in the state, in local arenas as well. We can specifically, if there's a specific question that you want me to take back, I'll be more than happy to sit with you to ensure that we get the answers that you need, okay?
That's great. I'd like to thank all our panelists and all you for participating. And I'd like to leave, I'd like to leave our policy discussion with a few closing comments with a kind of a broader narrative and strategic vision of how do we address health equity. We are on the stage Black practitioners. We are in the audience Black practitioners and allies. We are the Black Health Summit of 2024. We are at the historic Florida Memorial University, the only HBCU here in South Florida. And so we spoke obliquely, and we're speaking obliquely at this conference and this summit about ideology and its conflict with data. And so I want to elevate for our narrative change anti-Blackness. Anti-Blackness is the ideology that we all understand as the undercurrent and the dynamic that we confront in every policy discussion in which we engage. It is the force against which we must fight to advance any health policy outcome. Anti-Blackness, and the historical perspective is important because we're in a context where we don't want to teach our history, but the most important history that we're confronting right now is the history between 1980 and today, and how anti-Blackness has been camouflaged and institutionalized and rationalized in a theory of conservatism and reactionary conservatism. And that philosophy, as a political ideology, has legitimized fiscal conservatism, the lack of big government, market solutions, states' rights, all while impairing collective ability through government to implement policy solutions through the government, or undistort market forces to improve health outcomes. This is the change from a meta narrative change that we must engage in going forward. And this change, elevating anti-blackness, and I don't want to say racism because racism has no valence or direction. Anti-blackness has a valence, a direction, it conveys hierarchy and subordination. And so when we talk about health equity and addressing health equity, we need to incorporate an anti-blackness frame and how conservative ideology, whether you agree or not, empirically, it is the handmaiden of anti-black ideology. And if we're not going to be able to recruit the power of government and undistort markets to make healthcare solutions, then we're going to continue on this path. So I wanted to elevate that because it is the air in which we breathe. And for us as advocates and engaging in the political determinants of health process, whether it's voting, influencing government, and influencing policy, that is a long-term narrative change that we need to address. So I'm going to leave you with that. And that's my perspective as a public policy advocate. Reducing power imbalances is like shifting the narrative so that we can address these destructive, frankly, dynamics that are creating these harmful and deadly health disparities.
And the people said, amen.